Hello, I'm Julien Edeline. I'm a medical oncologist from Rennes, France, and I'm presenting you with, on behalf of my co-authors, a systematic review about the role of locoregional treatment for intrahepatic cholangiocarcinoma. Just as a bit of background, intrahepatic cholangiocarcinoma may present as an unresectable liver-only disease. So different locoregional treatments have been applied for these patients. However, the value of those have not been clearly defined. We thus performed a systematic review searching for studies published in PubMed and Embased, focusing on the following treatments: ablation, external beam radiotherapy, and intra-arterial therapies, including transarterial chemoembolization or TACE, radioembolization, also known as CERT, and hepatic arterial infusion of chemotherapy. This is the flow chart of the article. So we found more than 6,000 entries with the review of the title, abstract, and full content. We selected 93 articles, including 101 cohorts of patients. Overall, 3,990 patients were included. We had 15 cohorts of ablation, 18 cohorts of external beam radiation, 27 cohorts of CERT, 22 cohorts of TACE, 16 cohorts of hepatic arterial infusion of chemotherapy, and 3 cohorts with mixed combined therapies that could not be pooled with one another. This is the description of the studies. I will not come in all the details, but what we can see is that the vast majorities are retrospective studies. A minority were multicentric cohorts. Most of them had no or inadequate control group. As a quality control, we did an evaluation of the risk of bias based on the previous quality, and most of the studies have high risk of bias, showing a low quality overall of the literatures that do not allow to draw a strong recommendation. As the description of the cohorts included, we show that we have an heterogeneous population. The median number of patients per cohort is 25, so small cohorts overall. The population is not always clearly defined. For example, the knowledge whether there is an underlying cirrhosis is described only in less than half of the studies and half of the patients. Also, the patient could have been previously exposed to chemotherapy or not. Half of the population were not previously treated with chemotherapy. But we have this information in less than half of the population. As regard to the extent of the disease, there is also a quite heterogeneity. The volume of the lesion is overall 6 centimeters, but there is high heterogeneity as we can expect from the different modalities, with ablation having lower size lesions, while intrahepatic therapies have highest tumor burdens. This is also the case as regard to the extent of the disease defined as bilobore multifocal. Also, there are various extent of extrahepatic spread. Overall, a quarter of the population had extrahepatic spreads, which raised question about the value of locoregional treatment in patients with who do not have liver-only disease. When we look at the description of the treatment, ablation has mixed modalities, mainly radiofrequency ablation, also mixed modalities for external beam radiotherapy, with stereotactic radiation being the most frequent. Radiation was frequently done with combined systemic chemotherapies. As regard to intraarterial therapy, also mixed modalities with for third, either glass or resin microsphere. For TACE, either lipioidal or dilated eluting beads. For hepatic arterial infusion, various drugs used, as well as frequently used of concomitant systemic chemotherapy. These are the main results as the pooled outcome from survival. Of course, survival are different across modalities because population included are different. However, we do see very good outcomes for ablation with a mean pooled overall survival of 30 months, which can be quite similar to what is achieved in surgical series. For intraarterial therapies, mean survival ranges from 14 months to 21 months. As regard to response rates, once again, heterogeneity of results also depending on the heterogeneity of the population included. But when we look at ablation, there are very good and non-heterogeneous complete response rate of 94%, which is in contrast with result of poor response rates for other modalities ranging from 23 to 41%. These results are summarized in these figures when we do see increased overall survival with ablation as compared with other modalities, but we also see wide confidence interval for most of the modalities. Results for progression-free survival is less well described in the literature, with results in less patient included in the pool results and even wider confidence intervals. We then trying to combine results for intraarterial therapies. The main objective here was to focus on subgroups that may derive better benefit from this treatment, namely a patient treated in first line and patient treated with concomitant chemotherapy. And indeed, we do see improvement of result. When we look at all patients combined for intraarterial therapies, we see a pool mean overall survival of around 16 months, which goes up to 21 months for first-line patient, and first-line patient treated with concomitant chemotherapy increased overall survival of 25 months. The same trends exist for pooled response rates and also for pooled secondary resection rates. This is the illustration of these results in the figure, when we do see that pooled overall survival improve when we select the patient with first-line patient only and treated concomitantly with systemic chemotherapy. If we try to summarize the evidence from this literature, the patient population is there. We found numerous publications, more than any previous systematic reviews on any of these modalities. However, the evidence is limited by the poor quality of the data, mainly derived from the design of the studies, which are mainly retrospective single-center studies. Also, we lack some important information about the population, such as the performance status, cirrhosis, which are described only for less than half of the population. These results in heterogeneity of the results based on different population and difference of treatments, which make it difficult to achieve good recommendations. However, when we try to summarize the results, we do see for ablation that we have non-heterogeneous results with 94% complete response rates. Also, median overall survival of 13 months, it's suggestive of good control, similar to surgical series, even if the population are different. For external beam radiotherapy, the results are quite heterogeneous. Local control appears at 70% at 2 years, and it might be viewed as insufficient to derive strong recommendation. For intraarterial treatments, response rates are similar than first-line chemotherapy. Also, we might discuss a trend for better results for hepatic arterial infusion, but there are some caveats for this conclusion because the population is different. There is also a better staging by laparoscopy for a patient included in hepatic arterial infusion chemotherapy studies. First-line survival data for intraarterial treatment suggest higher overall survival and progression-free survival than systemic chemotherapy, and this might be the best population to study this treatment. If we try to suggest some recommendation, only ablation achieve moderate level of evidence for strong recommendation based on non-heterogeneous results about complete ablation rate and good overall survival. Weak recommendation could only be made for other modalities based on low level of evidence. And this recommendation should be made only in a very limited population. For example, for external beam radiation therapy, it should be performed only when resection or ablation is impossible. For intraarterial therapies, it should be only in chemorefractory patient or in combination with systemic chemotherapy when used in first line. I thank you for your attention and happy to answer any question by emails if needed.